today. As I was mentioning to you before, we always look forward to your yearly updates from ACC and all the new trials and evidence that was presented there. So I don't want to take more of the time away, so I'll just turn it over to you for now.
Great, thanks so much, and thank you all for joining us today to talk about the American College of Cardiology late-breaking trial sessions for 2023. I'll start off by, again, congratulating all of our fellows, faculty, collaborators that participate in ACC 2023, including presenting at various sessions, giving invited talks, and congratulate Carol Watson for her Bernadine Healy Award and recognition from the ACC. That was really spectacular. Selected a couple of the late-breaking clinical trials to cover here. Obviously, there were a lot more than we'll go through. Also note my disclosures. So let's kick it off with the first trial for consideration. That's the CLEAR outcome trial. So cholesterol lowering with bempedoic acid and ACL inhibition. And this was focused on individuals at risk for or with atherosclerotic cardiovascular disease, but reported to have statin intolerance. So his background here, clearly statins have revolutionized our ability to prevent and treat atherosclerotic cardiovascular disease, lowering LDL and ApoB, and mainstay of prevention for atherosclerotic events. But there are reported various degrees statin intolerance, and there are individuals that perceive intolerance that may not be there. There are individuals that, for whatever reason, are reluctant to take statins, and then there are some that truly do have intolerance. So an ATP citrate lysate inhibitor, bempedoic acid, which inhibits hepatic cholesterol synthesis. This is upstream to the HMG-CoA reductase, the enzyme that's targeted by statins. This is a prodrug that's activated in the liver, but isn't activated in the peripheral tissues. So in a sense, there has been reported in the preliminary data low incidence of muscle-related adverse events, but as you'll see, there are some other considerations with this drug. Based on its LDL cholesterol lowering, this drug was approved, but clearly most clinicians want to see longer-term safety and importantly want to see outcomes that not just that LDL has been lowered, but they're not off-target effects that could counteract that, and that in fact translates to better clinical outcomes. So the design here was to basically, because it'd be very challenging, not on a background of statin therapy, to withhold a standard of care therapy. So there are a variety of ways of thinking about doing outcome studies in the statin era, looking at incremental benefit. But here, this approach was to look at those individuals with reported statin intolerance, so an adverse event that started or increased during statin therapy and resolved or improved after therapy. There had to be intolerance to 2 or more statins, or if there had been intolerance to one statin, the patient had to, vouch that they were entirely unwilling to attempt a second statin, or were advised by their physician not to attempt a second statin. Patients could be on very low but less than guideline recommended statin dose therapy and still get in the trial. So this is relative intolerance. So it could be completely intolerant or not tolerant of intermediate or full doses, depending on the clinical circumstance. The trial enrolled patients that would fall under the category of primary or secondary prevention. They had to have a documented LDL cholesterol in their background therapies of 100 or greater. And then they were randomized to bempedoic acid, 180 milligrams once daily, or matching placebo. This was an event-driven trial, so needed 1,620 primary 4-component MACE endpoints, and we'll go through that. The 3-component MACE endpoint, there needed to be at least 810 of those, and mandated to go at least 24 months of follow-up But once the number of events had been reached, if greater than 24 months follow-up had been achieved, the trial could be stopped. So regarding the statin intolerance, they did have the patient actually confirm and sign a form asserting their statin intolerance. We recognize this could be, somewhat like, don't you want to be in this trial, and get them to sign the form, but this is at least what they acknowledged and signed on. And in addition, the clinician had to have a statement that they then signed. In my opinion, this patient is unable to tolerate statin therapy except possibly at very low average daily doses based on my review of the medical and medication history and discussion with the patient. So these were documented in each of the patients enrolled. So the 4-component MACE, so non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death. So clearly there's some discretionary perception on who undergoes coronary revascularization. So the 3-component MACE that required at least 820 events were MI, stroke, or CV death. There was hierarchical testing of the secondary endpoints, which included the 3-component MACE, and then fatal and non-fatal MI, then coronary revascularization, and fatal and non-fatal stroke, then cardiovascular death. And each of these sequentially were reaching significance, could then go on to look at all-cause mortality. So these are the primary and key secondary endpoints. So close to 14,000 patients at 1,250 sites in 32 different countries were randomized. Enrollment ran from December 2016 to August 2019. Median follow-up duration was well beyond the 24 months, so out to 40 months. So, this is longer than some of the original trials of PCSK9 inhibitors, not quite as long as some of the very original statin trials like 4S, but 40.6 months. Despite the pandemic, there was complete assessment of the primary endpoint in 95.3% and vital status in 99.4% of patients. So well-conducted study with regards to complete assessment. And the 4-component MACE occurred in 1,746 patients and 3-component MACE of 1238. So at least for the powering, the trial appeared to as if the event rates were close to what were assessed, would get to where they needed to be. So here are the baseline characteristics. So you can see the mean age in the 65 range. This trial, notable because close to half the individuals enrolled were women, were female. And, this is a much higher percentage than other primary or secondary ASCVD prevention trials. So kudos to the investigators in that regard. You can see with regards to race, ethnicity, diversity, relatively narrow population is shown here. And LDL cholesterol 139, remember, should be at baseline 100 or above. HSCRP at 2.3. 30% of patients were in the high-risk primary prevention, 70% secondary prevention. So, 70% had documented ASCVD. Diabetes in the 45% range. And, more than 75% on no baseline statin use, and 22.9% had baseline low statin use. So, largely looking at a population with ASCVD that were not on statin therapy. So let's look at the reduction in LDL cholesterol. So this looking at percent reduction, you can see over time in the placebo arm, first 6 months, very little going on, but gradually some decline occurring over time with regards to at maximum at 54 months was about a 10% reduction. Contrast with bempedoic acid, we've got 21.7% reduction at 3 months, maintained there at 6 months. We can see at 30 months still is about a 20% reduction. And then as we get a little farther out and number of patients not followed as long, we're at 26.1. So that separation at various points is somewhere around a 20% net difference in relative reduction, narrows a little bit over the course of the trial. So if we look at this 22.2 at 6 months, at 12 months, 20.6, end of study, 19.4 in that regard. Okay, so how about for our 4-component MACE primary endpoint? You can see really curves begin to separate somewhere around the 6-month mark, continue to separate. Overall a 13% relative risk reduction, absolute risk reduction 1.6%, the 95% confidence intervals 0.79 to 0.96, so between about a 21 to 4% relative risk reduction. The NNT then to prevent the 4-component MACE over that median follow-up of 40 months was an NNT of 63. So in absolute and relative terms, this is a modest benefit, but was discernible. And for this primary endpoint, there was a clinical benefit demonstrated. Now, if we look at the 3-component MACE endpoint, so excluding coronary revascularization, here we've got hazard ratio 0.85, confidence intervals do not cross 1.0, p-value 0.006, and the absolute risk reduction of 1.3%. So that NNT is going to be even a little higher, more on the 75-80 range. You can see the event separation is about the same, and ultimately the difference there is reaching statistical significance and potentially clinical relevance. Now, if we look at non-fatal and fatal MI, here a little greater relative risk reduction, 23% relative risk reduction, 1.1% absolute risk reduction. This curve divergence, a little same time frame, but then kind of at 6 months diverges a little to greater degree. If we look at coronary revascularization, 19% relative risk reduction, 1.4% absolute risk reduction. Fatal and non-fatal stroke, this does not reach statistical significance given the smaller number of events, but is on that order of about a 15% reduction. And there were relatively few patients hospitalized for quote unquote unstable angina, but this did have a hazard ratio of 0.66. Now, when we look at cardiovascular death, though, so fatal events, here, even over the course of the trial and out to the 60-month mark, we are not seeing even a trend for reduction. Hazard ratio 1.04, so actually numerically slightly a higher number of cardiovascular deaths. Confidence intervals 0.88 to 1.24. This is a little different than we'd say from some of the other trials where, maybe in the first 12 to 24 months, we did not see a separation with regards to CV death, but after that did, here not seeing it. And for all-cause mortality, also no significant difference here, and hazard ratio 1.03. So something to keep in mind as you interpret the trial. Now, what about investigator-reported adverse events? So in these trials, right, you're going on a lipid drug, individuals will often report adverse events, and you can see that that adverse event rate receiving sugar pill was 1 in 4 patients over the course of the trial, and not significantly or clinically different with regards to study drug. Adverse events leading to drug discontinuation, also very comparable to placebo. Importantly, with regards to any muscle disorder, you had 15% of patients reporting this drug that you were giving you was causing a muscle disorder that's notable, even when they were receiving placebo, and clearly not even a trend as higher. Statins have been associated with a slight increase in new onset diabetes, not even a trend here. So reassuring for both those concerned with myalgias or muscle disorder and new onset diabetes. Liver function test, 4.5 being greater than 3 times upper limit of normal, 4.5 versus 3. Predefined renal events, though, notice this is higher, 11.5 versus 8.6. There was also a higher rate of gout, a higher rate of cholelithiasis. So, these are on the order of about 1% in absolute terms. and adjudicated tendon rupture, pretty similar, though slightly higher in bempedoic acid. Okay, if we look at the primary endpoint across clinically relevant subgroups, we don't see much of a way of interaction, but greater than 75, there possibly a little attenuation, but the confidence intervals overlap. No difference with regards to males and females regarding efficacy. Interestingly, and perhaps a little counterintuitive, but maybe a little differential in the background statin use, primary prevention appeared to be a little more robust in benefits, even though the confidence intervals do overlap, so may just be play a chance compared to secondary prevention. Baseline LDL, possibly a little attenuation, the greater than or equal to 160, a little counterintuitive there, but again, no heterogeneity or interaction. And then by baseline glycemic status, normal glycemic prediabetes, diabetes, not much interaction seen there. So trial enrolled only patients with documented statin intolerance, so that should be kept in mind. Effects in other populations not studied, and in particular being on maximally tolerated statin, where most patients are on high intensity statin, the incremental benefits have not been studied in this trial, and thus need to be inferred or separately studied. Addition of other therapies over time, narrowed the difference in LDL. And may have attenuated some of the benefit that would have been seen if drop-in of other lipid-lowering therapies had not been allowed. And of course, there were some loss to follow-up for complete follow-up, in part due to the pandemic. There's still 95.3% is pretty good. So what we conclude from this trial that the therapy was, in general, with some exceptions, well tolerated in this primary and secondary prevention trial, with the overall adverse event rates comparable to placebo in patients that were unable or unwilling to take recommended doses of statins. Bempedoic acid lowered LDL cholesterol by 21.7%. HSCRP was actually an inflammatory marker, reduced by 22.2%. There were, however, some small increases in the incidence of gout or cholelithiasis, but from statin side effect profile that we often, the concerns about muscle or diabetes, did not see a difference there. Primary endpoint, 4-component MACE at 13% relative risk reduction, 3-component MACE 15%, MI 23%, coronary revascularization 19% relative risk reduction. So these findings do give us clinical outcome data and shows that in patients of truly intact tolerant of statins, that major cardiovascular events can be reduced with this agent to a modest degree, and generally with a well-tolerated therapy. So with that, I'll be happy to entertain questions or open this up for discussion or additional comments. And Carol, your thoughts on this study?
Yeah, just really quickly, underwhelming. 2, anyone who's done clinic with me knows you can get almost everyone on some dose of some statin and most patients up to target doses. 3, the LDL reduction is essentially exactly what you get with Zetia. The difference is Zetia has shown to have independent additional risk reduction on top and above statin therapy. This therapy has not. I just don't see a strong role for this.
The Asparian stock went down by 20% on the day that this was published.
Oh, I guess the market got it right.
Which I think people just weren't impressed by the extent of protection from coronary disease.
Yeah, I think, certainly having outcome data is helpful, but also the magnitude of that outcome reduction. On one hand, you could say, given the modest lipid LDL differences, this is somewhat in line with that, but certainly, very modest. And as Carol highlights, you really can get the vast majority of patients if you work with them on statins. We do have other therapy that has outcome data. There are few patients that truly are statin intolerant and using other lipid agents that they have access to. Obviously, there are far more potent LDL reduction that can be achieved with PCSK9 inhibitors, and growing number of choices there, including a trial that was looking at an oral PCSK9 inhibitor that's in early stage development. So we will see the evolution. Any other comments, thoughts, or questions? Okay, hearing none, we will go on to the next trial that also generated a lot of talk and different thoughts and views. So this is looking at clinical trial of transcatheter repair for tricuspid regurgitation. So we know that TR is common, and perhaps more recently has gotten focus and shown that independent to other structural abnormalities has been associated with poorer quality of life and more symptoms and lower survival. And there's been a lot of discussion and debate. Is that because of just a reflection of what's going on in the left side of the heart, or pulmonary hypertension, or is TR in of itself independently contributing to the symptoms and impaired survival? Addressing it surgery-wise, very select patients, and the outcomes have really been mixed. So mostly we've been utilizing diuretics, loop diuretics as the main therapy, and it's not been very satisfactory. So limited data exists with right-sided valvular disease, and often what's done is kind of inferred with what's going on with the left heart. Even if you think about how we treat right heart failure, it's kind of inferred of what works on the left ventricle hopefully works for the right, but some of the trials really haven't even panned that out. So transcatheter therapies clearly have evolved for the mitral disease. We've got the COAP trial and other therapeutic approaches there with regards to MitraClip and other devices. But there's been a lot of interest recently in transcatheter tricuspid therapies. They've emerged, but we've gotten some case series and otherwise, but studying the benefit in a rigorous randomized controlled trial is clearly important. So TriLuminate, pivotal trial, was designed to look at the safety and effectiveness of transcatheter tricuspid repair using the so-called TriClip device in symptomatic patients with severe TR who are intermediate or greater estimated risk for mortality for a tricuspid valve surgery. So thought to be higher risk for surgery, not absolutely contraindicated, but could be a candidate then. So here's the TriClip and its G4 delivery system. So those who like gadgets, here it is laid out for you. You can see this controlled gripper actuation. There are 4 different clip sizes as illustrated here. And I'm sure if you have any questions about this, Marcy or the other structural interventionalists can tell you further details about this. So here was the key inclusion criteria. You had to have severe TR, but also symptomatic. So severe symptomatic TR. You had to be on stable guideline-directed medical therapy for your heart failure and gotten device. It had to be greater than 30 days ago, and thought to be using a risk score at an intermediate or higher risk for morbidity and mortality undergoing a surgical treatment for your tricuspid disease or other disease that you would have concomitant with that. Indications for other valve interventions was an exclusion criteria. Those with severe pulmonary hypertension, an LVEF less than or equal to 20%. And if your anatomy was not thought to be suitable for TriClip therapy, you were also excluded. So you can see the steady flow. There was actually a core lab used. So, it wasn't just the investigator saying, oh yeah, it's severe TR, let's get the patient in. So there was a core lab that had to confirm TR severity being severe to get in the trial. There was further confirmation regarding being optimized and medical therapy and clippable. And, after you'd done the meds, that ability and thought that you'd be able to reduce that TR to moderate or less. And so patients randomized to TriClip device for plus medical therapy or medical therapy alone, and follow up for 12 months. Now, if weren't thought to be amenable, patients were then followed in a registry. So you have the randomized design and then following. So 450 subjects enrolled in 80 sites in the US, Canada, and Europe. The primary endpoint to be assessed after the first 350 patients randomized and completing 12-month follow-up. So composite of mortality or tricuspid valve surgery, heart failure hospitalization, but also quality of life improvement by 15 or more points using the Kansas City Cardiomyopathy questionnaire. And they used a hierarchical approach using the Finkelstein-Sloanfeld methodology. But notice there is the report of Kansas City Cardiomyopathy questionnaire, and this being a device trial without a sham control, patients and their clinicians knew exactly how they had been assigned, and thus were aware of that as they were completing this questionnaire over the course of the trial. Secondary endpoints for freedom from major adverse events with the procedural attempt at 30 days in the device group, change in the Kansas City Cardiomyopathy questionnaire at 12 months, superior device versus control. Also looking at TR reduction to moderate or less at the 30-day point post-procedure, and change the 6-minute walk at 12 months, and looking for superiority of device versus control. So you can see the patients older here, right? 78, over half were female, New York Heart Class 3 or 4, and 55%. KCCQ score at baseline was in the 54 to 56 range. Comorbid conditions, including a lot of atrial fibrillation, as you'd expect in this population. Use of CRT, permanent pacemaker or ICD in about 15% of patients. Prior aortic or mitral interventions in 15 and 25%. Prior tricuspid interventions only in a single patient. You can see the severity in these patients of being high, and a fair number of torrential tricuspid regurgitation. So you have either severe, massive, or torrential. You can see the coaptation gap documented here. You can see right ventricular end diastolic dimension and centimeters at 5.52. Tricuspid valve annulus diameter at 4.3, 4.5. The TAPSE for the RV at 1.6 or 1.7. LVEF largely preserved in this group, as was cardiac output rest of 4.1, 4.2. So here's reduction in TR severity. You can see, with regards to the medical arm at 30 days, really nothing changed here, 95%. Still it's severe, but you can see this really very substantial improvement to moderate or trace or mild occurring, so going to only 13% continuing to have a severe TR in the device arm. So, and close to half being at trace or mild, so impressive. So looking further then in the paired analysis, 30 days and at follow-up, so that was largely maintained. So continue to have severe or worse TR in the medical arm, and really sustained out through the 12 months shown here. So really impressive in that regard. So the primary endpoint, again, this hierarchical approach using sort of a win ratio. So the win ratio is 1.48, confidence interval is 1.06 to 2.13, the p-value hits 0.02. What drove this win ratio? Well, when it comes to death or needing open tricuspid valve surgery, we really see no significant difference here, very similar. Heart failure hospitalization, if anything, trending to favor the medical control arm. So although not statistically significant, clearly in the wrong direction. And so what really drove this hierarchical approach was more patients reporting a Kansas City Cardiomyopathy Questionnaire change of 15 points or greater, highly statistically significant. So, that'll be a debate point. So here, when we look at the individual component analysis for the first component, mortality or TB surgery, we really see, superimposed upon each other for device and control. And for heart failure hospitalization, if anything early on was favoring control, then kind of, towards the 9-month mark sort of comes back together, and overall no statistically significant difference, but not seeing any favorable trend emerge here through the 365 days of follow-up. Remains to be seen with longer term follow-up whether something would emerge. With regards to looking at the details of the Kansas City Cardiomyopathy Questionnaire, so worsening, less likely in the device arm, 40% versus 18.4. If we look at improving by 5 points greater, 10 points greater, and close to half reported 15-point or greater improvement on KCCQ versus only 26.4 for those on the optimal medical therapy arm. So we really see that, this was the driver of the primary endpoint and largely consistent no matter how you sort of cut the KCCQ, but again, patients knew. So this is looking at the relationship between TR and quality of life. So did able to show those that continue to have severe massive torrential tricuspid regurg, the improvement in KCCQ was more modest and greater in those that got to moderate or less. So you'd say, well, maybe it's reflecting something physiologic in that regard, and not all just driven by, I had this nice new experimental procedure and I'll report improvements to make the investigator happy. So certainly there may be some component of that. If we look at major adverse events, actually reasonably safe here through the 30 days. So only a single death, endocarditis cases not detected, only 2 new onset renal failures, and non-elective emergent surgery not seen. Other things going on, there were 3 patients needing re-intervention. There were some major bleeding, 4.7%. There were some patients left with a gradient of 5 or higher. So maybe a clip a little too aggressively. In that regard, only a single stroke and not thrombosis or embolization or MI. And a single patient required a new device to be placed. So with regards to the limitations, I think very importantly, patients were not blinded. A Hawthorne effect may have played a role. Data I didn't show you, 6-minute walk didn't improve, hospitalization didn't improve, survival didn't improve, but patients were less symptomatic and their TR went down. And then it was conducted during COVID-19, so some of the outcomes could have been impacted. So summary, TR was reduced with the triclip therapy to moderate or less in 87% versus only 4.8% in the medication control group. Reduction was sustained pretty reliably through a year of follow-up, so that's impressive. Primary endpoint on the win ratio was met. So device, on one hand, you could say is superior, but this was driven mainly by the improvement in quality of life and not by the other aspects. The degree of TR reduction was associated with that degree of improvement in quality of life. The 30-day major adverse event rate, only 1.7%, and death or pacemaker implant, only 0.6%. And survival-free of mortality or tricuspid valve surgery was generally high at 1 year, but in both arms, so greater than 90%. So, demonstrating for heart event reduction and improvement here with the device through 12 months, really not demonstrated. So, pioneering study with regards to treating severe TR, highly effective in reducing that TR that was associated with improvements in quality of life, with the caveat is patients wasn't sham controlled. They knew how they were assigned, and would certainly make the case that to reassess the impact on symptoms would want a sham control. These results could be very meaningful or could be impacted by that unblinded design. Importantly, for heart events, though, hospitalization, mortality, 6-minute walk improvement were not seen. But overall, device safe, and certainly could consider this setting the stage for additional trials, though certainly some may say, oh, we reduced TR, patients feel better, everybody should be treated. So this was published New England Journal of Medicine, and welcome comments, thoughts, or questions regarding this trial.
Thank you.
Greg, this is,
Greg.
I have a quick question for Marcy or Greg. Do you know what proportion of patients were not amenable to the procedure?
Yeah, there's a high screen fail rate, very, very high, based on anatomy, which is, I think, one of the problems with, I think, making this a standard, because there's the tricuspid valve is so complicated. And right now we're screening for CLASP, which is a very similar trial using the Edwards device. And it's basically, I think that with the Triluminate, they had similar criteria for, the valve anatomy having to be favorable. My thoughts for this are a few. So first of all, the TR reduction is still, even though there was TR reduction, it's much less than they ever got in COAPT. And I think that the patients, when you look at heart failure, and this is a question I have for Dr. Fonarow and the heart failure team, as I see a lot of TR patients, their symptoms are sometimes not clearly left-sided, right? So TR patients may have edema, liver congestion, and renal failure, but may not necessarily be hospitalized for heart failure per se. So that's just an interesting question about, the outcome. Not necessarily, when you look at the tricuspid side, is it fair to necessarily look at heart failure as one outcome, as we, and rather actually maybe look a little bit more about, look at right-sided heart failure symptoms specifically, like edema, diuretic dosage. And these also usually excluded patients with renal failure and liver failure, which are also one of the markers of, bad right-sided heart failure. And again, so these trials exclude those patients. So if you have liver disease or kidney disease, you're on dialysis, for example, you're excluded, or near dialysis. And then also this trial showed a 7% SLDA, which is a really very high. I mean, in the mitral side, a single leaflet detachment is like less than 1%. So a 7% means that a certain percentage of your patients, nearly 1 in 10, might end up with a device complication. So I still think that's also something to consider. I think that the CLASP trial is going to be another very helpful trial to determine whether this technology is worth pursuing or not. I think that the KCCQ, as Dr. Fonarow mentioned, it being an unblinded trial is a very difficult thing to interpret, because the 6-minute walk test is the same. But I guess my question really is more, when you look at the right side, what are we looking, what should our outcomes really be? Should it be renal failure? Should it be liver failure? Should it be edema? Should it be ascites? Should it be fatigue? Because I also just, when I see these TR patients, they're not the same as the mitral patients or the COAPT patients. They're just different. So I'm just curious about other people's thoughts on that.
Yeah, I think Marcy raised an excellent point. Obviously, the thresholds for hospitalization with right heart failure are different than left heart failure, where there's the associated shortness of breath and raises a whole host of additional concerns. So, there can be a lot of debate around, the endpoints and, even the degree of functional impairment. You improve the TR, but, chronic debilitation may not, structurally rehab these patients to where then you detect a difference in their 6-minute walk. So I think all of those are relevant. It is, would be more pure in looking at symptomatic improvement to have a sham control, because then you can completely eliminate that aspect of things. And we have seen pretty impressive responses to devices being placed, CRT without it turned on in that regard. So I think this will evolve and we'll see additional trials. And you could also make the case it would take over a longer period of time to start seeing more events than just 12 months and significantly reducing the TR. And as you pointed out, it was a reduction, but not as great as we've seen on the left side. And there may be able to improve further on the device technology and skills in implanting to further improve upon that. Other comments or questions?
Was there any relationship with outcomes with RV function recovery?
Yeah, that's a great question, Henry. They really did not report on that. I'm imagining there will be some secondary analyses that will look at that in detail of right heart function and how that evolved over time, because I think that will provide insight, and then whether that then with longer term follow-up provides additional insight that you will see.
Yeah, I think they also excluded patients with significant RV dysfunction. So at least in the CLASP trial, they're pretty careful about not including significant RV dysfunction in these studies. But so you may not see much of a change if most people had only mild, moderate RV dysfunction to start with. But I actually don't think that, I don't think this will lead to FDA approval. That's just my personal thought. I think they're going to push, the companies push for symptomatic improvement. They're going to commercialize the idea that, look, if you don't feel well, this may make you feel better. But as we say, that's with, I think that's a grain of salt, just the way the trial was run. I think we need to look at the CLASP trial. I really think that if any one of you guys have any patients with severe TR that you want me to take a look at, I think it's really important that we try to enroll in that trial. It has about 6 months more time for enrollment. So please, send us your TR patients so that we can address this question with another trial, I think, before we start to roll it out in patients.
Yeah, I think that's an excellent point.
Do you get a sense that the RV is a much more resilient chamber, so that those with severe RV dysfunction may be those that may benefit the most?
Well, what they're seeing on I know what they're seeing on the TTVR side is that they've had a couple of disasters in RV dysfunction. I don't necessarily think that the RV is more capable of recovery. I actually think it's the opposite. I think that when you have severe RV dysfunction, you have to be very careful with, significant reduction in TR, just as you do on the mitral side. But I think with tricuspid clip, you're just not going to get that significant, you're not going to get like trace, you're not going to go from massive to trivial. So I think that we don't need to worry too much about that on the TR side. But if you go to TTVR and valve replacement, I do think that there's going to be a real, you're not going to be able to, replace the valve in patients with severe RV dysfunction, because I think they've not done well.
Great. Interest of time, great discussion. Let's move on to the next one. This is a implementation science based study, so called Better Care, HF, Building Electronic Tools to Enhance and Reinforce Cardiovascular Recommended Therapy for Heart Failure. So, MRAs have been demonstrated in randomized clinical trials to really substantially 30–35% reduction in all-cause mortality in patients mild, moderate, severe heart failure, despite the proven benefits, despite generic availability. 65 to 75% of patients in the US that are eligible for MRAs are not receiving them. This has something to do with fears about hyperkalemia monitoring, clinical inertia. We had published the estimates about the number of lives that could be saved if this gap could be bridged, and cited by these investigators. So obviously an unmet need that's been going on for 2 decades, and a few interventions like Improve HF, we were able to show significant improvements, but even in recent data in CHAMP HF, there was a very large gap. So electronic health records, the bane of many clinicians' existence, but at the other hand, low cost, scalable, and potentially, some studies have shown improved prescribing. We had covered the PROMPT-HF study that looked at 4 therapies being improved, including MRAs, that was published in JACC. So this is the background, but there's been, wide variability, and some interventions really haven't shown improvement. The optimal delivery and timing of EHR tools is unknown. So, you can send messages, you can send alerts through best practice advisories. And, here's some of the pros and cons. So, that's part of the background. The better care HF hypothesis was among patients, heart failure reduced EF, evaluated by cardiologists. So this was an intervention designed for cardiologists in the outpatient setting. Getting an alert or a message would improve the prescribing of MRAs as compared to usual care. And they also hypothesized alert would be more effective than a message at improving prescribing. So here's how you got in. You were an adult. You had EF that was most recently 40% or below. You were not already on an MRA. They tried to exclude if you were documented to have an SBP less than 90, if you had hyperkalemia on the most recent K of 5 or above on your most recent lab, estimated GFR less than or equal to 30, or previously documented to be intolerant or an allergy to MRAs, and ventricular assist device, amyloid, or hospice. And so cluster randomization by cardiologists, so you were either assigned to an arm to get a bunch of these or not. So alert for a single patient at time visit, message for multiple patients between visits. Hey, here are your list of patients that are eligible for MRAs, and then usual care, no alert or message. 60 practices in NYU with Own Health were randomized in this regard. And so interactive development process, they actually engaged cardiologists, did some interviews, pilot testing, refinement. They use cognitive load theory, nudge theory, 5 rights of clinical decision support framework to try and avoid some of the alert fatigue and just, I'm too busy, leave me alone. And so, these were automated, EHR embedded and displayed at real time. So here is an example what it looked like, the alert alarm, nice big and red, heart failure medication alert. Here's the list of the current meds, aldosterone antagonist, none, displayed the blood pressure, displayed that potassium, displayed the EGFR. And then you could open your smart set in order, or you could, look through and say, nope, they're pregnant, or, oh, the EF isn't accurate, or, other, meaning don't want to be bothered. So the message arm here, you got your list of patients and the documentation on why they'd be eligible, sent monthly via the EHR. Physicians open the links by clicking, and then could decide what to do. Get this patient scheduled, let's call them up and just get them started. Or, let's, on the next visit, I'll try and remember. So primary outcome, new MRA prescription during the study period, and then making sure, did this affect other medications? Now notice things like, oh, was there hyperkalemia? Were lab tests done? You don't see that as a primary or secondary endpoint. So here was the sample size and pre-specified intention to treat and the modeling they used. Patient characteristics, so there were 2,211 patients, median age 73. In a heart failure reduced EF population, there are more men, so 71%, 69% white, 11% Hispanic, 69% were Medicare. You can see background ACE, ARB, ARNI, 74%, beta blocker, 80%, and seen by general or heart failure cardiologists, 75% before the visit. Okay, so here's the primary outcome. You can see with usual care, a new MRA prescription among those not previously prescribed, 11.7%. You can see a message It did reach significance, but 11.7 to 15.6. But compared to the alert at the point of care, greater improvement here. So compared to usual care, a relative risk 2.53, absolute increase, on the order of 20%. And even compared to the message, there was a significant improvement in relative risk 1.67. Number needed to treat to result in one prescription with the alert, 5.6, with the message 25.6. So 5.6 alerts getting one new MRA prescription with the cost per alert being microscopic. That's pretty good. So percentage of patients that were newly prescribed beta blocker, ACE inhibitor, ARB, or ARNI, you did see subtle differences here, but did not reach statistical significance. So 4.22834. So it wasn't like that focus on MRA was, wiping out focus elsewhere, though a lot of inertia, because the vast majority of patients, if they weren't otherwise treated, weren't studied. Pre-specified subgroups, interestingly, in the group where, older seemed to be a little more amenable there, but alerts worked in both, and general heart failure versus EP interventional. So there you go. But the alerts seem to work in regardless of your specialty, though a little greater at general or heart failure, P.04 there. Regarding patient sex, for again the alerts kind of no interaction, ethnicity, race, or by insurance, though public seem to be a little greater than private, not with the formal interaction. So limitations here, how would this work outside of cardiology? So generalizability, what about other health systems? A single med, specific selected for MRA, and really importantly, hyperkalemia monitoring. That is in the paper. There was a little more hyperkalemia, but only 56% of patients had a lab done for potassium within a month. That's a complete violation of the guidelines and good practice, where after an MRA being prescribed, within 7 days, the recommendation is for a lab check, and here even at 30 days, 40% hadn't been checked. So in conclusion, this automated EHR embedded, tailored, and selected alert delivered at the time of care more than doubled prescribing of MRA compared to usual care. The message did increase prescribing, but certainly not as much as a clinically actionable alert at the point of care. And EHR embedded tools can be rapid, low cost, high impact method, increase prescription of life-saving therapies, but clearly safety and further attention to that is going to be critically important. So this one is now open for comments, discussions, and thoughts.
Thank you, Greg. This is very interesting because, with our cardiology dashboard, and you've been involved, so we're kind of looking at the same thing and seeing how our provider, it's affecting prescriptions by our colleagues. Nick, one of our fellows, has actually started to look at this same kind of concept before we saw this trial, looking at MRAs, because we looked at it as kind of the low-hanging fruit within our division, because when we started the dashboard, we realized that we had been performing very poorly on that metric. Since the start of dashboard, we've actually have seen, about a 20% increase in MRA in our inappropriate patients, which is interesting, kind of similar to what Dave saw. The way we're doing our randomized trial, which Nick is heavily involved in currently, is we're trying to take the providers out of it to some extent, so there isn't as much fatigue. Obviously, you guys have seen, the alerts and like the cardiology care gaps when you log in. But in this situation, we're using the dashboard to actually behind the scenes look at patients that should be on an MRA, which are not. And then we're actually reaching out to clinic managers, and then these patients are getting scheduled with providers in a randomized fashion with a note on the clinic follow-up note that says consider starting MRA or GDMT. So we're trying to limit physician fatigue in that context as much as possible. So we're doing things behind the scenes and involving clinic managers and ancillary staff. And that's how it's a little bit different. So we'll see how those results come out.
Great, thank you for that. Other comments or thoughts?
Do you guys think there's any role? I know with AI coming up, I'm just curious, I know there's a recent AI looking at echo, use of AI and echoes. That was just in the New England Journal, came out of Cedars, or Nature, actually. I'm just curious, do we have any projects using AI and looking at, GDMT and heart failure? Are we using AI?
So there have been some articles about that. I mean, some of the use has been to try and actually identify eligible patients. So UCLA did a lot of background work that we worked on early to make sure ejection fraction is available in electronic health record, but there are some large systems where they actually cannot do that and need native language processing to try and abstract that, and have used AI for that. There are others talking about, can we have a chat GPT that actually will do the counseling for patients and get them to actually, get their medications on their own and prescribe it. So, we're an evolving role there, but you could imagine to where there could be a lot of interaction, your patient's questions all answered if they're identified before the visit of being eligible, get educated on the medication, come in, just check with you, and then, ultimately AI finds where they're going to best get that prescription filled, and orders the follow-up test and ensures they get reminders and prompts to come in to get the follow-up monitoring, and then alerts clinicians, patients, their family members if at the time the prescription renewal wasn't renewed or it wasn't dispensed. So there may be a lot of things that will evolve to make really smart systems that in many ways can, be far more reliable than just dependent on physician prompts or clinic managers or otherwise. So we'll see. It'll be rapidly and interesting, the evolution in that regard. Great. Any other comments or questions? Okay, so we're pretty much at the top of the hour. There was one more trial that I was going to cover, but in the interest of time, we'll send out a PDF of these slides. I want to thank you all for your participation in this session today, and have a great holiday weekend.
Thanks, Dr. Fonarow.
Thank you.